My name's Caroline Dunstan. I'm the Diabetes Specialist Nurse Lead for Cornwall and Ardersill Community Health Services, and I'm based at the Royal Cornwall Hospital at Treliske in Cornwall. Cornwall's a county in the United Kingdom based right at the very base of the United Kingdom. It has a fairly rural population with one district general hospital based in the middle of the county. I'm actually the team lead for the Community Diabetes Specialist Nurse Service. We're a team of 7 full-time equivalent nurses providing community diabetes services for patients across the whole of the county of Cornwall. Our service also provides an in-reach service to our acute hospital, so we have 2 nurses based within the Royal Cornwall Hospital providing specialist inpatient services. The difference in our team from some of the other teams within the United Kingdom is that we are one nurse team, regardless of whether we're actually working within the community services or specialist hospital services. The service that we provide is a nurse-led service, providing support to our secondary care consultant colleagues and also to primary care, so that's practice nurses and GPs. We take referrals obviously direct from secondary care. Also we have a direct primary care referral service from practice nurses, GPs, allied healthcare professionals, so physios, OTs, mental health services, from social services, and also we will take self-referral from patients who have previously been under the care of our service. In terms of our nurse-led clinic services, we have over the last 3 to 4 years moved the majority of our outpatient type clinic work out to the community, away from a hospital-centric based model to a very primary care and GP based model. Obviously this has worked very much to our advantage given current changes to the National Health Service and current changes particularly around community health services, and with up and coming changes that we're likely to see to the rest of this year, with potentially GP commissioning. Our service has already made that transition. The reason for making that transition has been wholly based on our geography and our patient population. We have several areas of quite high deprivation in Cornwall. It's a county that's always traditionally seen within the UK as being quite affluent. It's where people come on their holidays. The sun always shines. We all live next to the beach and next to the river and have lots of money. The reality for Cornwall is that there's no industry other than tourism. We have several industrial towns which are now very run down and, as I said, have areas of deprivation. This gives us a very mixed population, from the very affluent to the very poor, and obviously with that comes a very different set of healthcare needs. We have very poor transport links, and what we were finding was that running traditional hospital-based nurse clinics, our attendance rates were poor and we weren't actually getting the patients we needed coming to clinic. So our clinics now really follow 3 main models. The first one is a very traditional nurse-led based clinic. Now that can take place either within a community hospital base, of which we're very lucky in Cornwall. We still have a lot of our community hospitals in most of our major towns. The second would be to use the GP surgery as a base for the clinic, and we may see those patients independently just using the surgery as a geographical location. We may also run a joint clinic with a practice nurse, or we may run a joint clinic with the practice nurse and the GP. Our nurses are based with holding a geographical caseload, so each specialist nurse will cover somewhere between 10 to 15 GP surgeries. And that nurse then divides her time depending upon obviously the setup of the GP surgery, the number of patients they have registered with diabetes, and the severity of cases within that individual surgery. By running clinics this way, what we've found is that it's a much easier to form relationships with practice nurses and GPs, and as we all know, working clinically, if clinicians have formed a professional relationship, you know how they work, they know how you work, you can pick up the phone, they know who you are. Those channels of communication are much stronger. People are much more likely to ask for advice, ask those questions that maybe before they would have been a little more formal and not ask. The other thing that those clinics allow you to do is to actually use them as an education opportunity. So we've found that by running our clinics within general practice, we are able to upskill and increase the confidence of both our practice nurses and our GP colleagues. What the benefit this adds for the patient is obviously with the growing number of patients with diabetes. In Cornwall currently we have around 25,000 patients registered with diabetes, but within the next 10 to 15 years predicted to be somewhere around 56,000 patients. Given the current NHS climate, we're very unlikely to get more specialist nurses. So therefore, we've spent quite a lot of time trying to think about how we can work smarter, how we can actually still use our expertise to the best possible way and get that expertise to the most patients that we possibly can. And the way to do that is actually to work in conjunction with our primary care colleagues, rather than holding our speciality, becoming precious about our speciality, actually going out there and saying there are lots of bits of diabetes you can manage that you are best placed to do, we'll support you to do it. There will still always be a core part of those patients who will need the specialist nurse service, but what it allows you to do is to triage those patients so that everybody gets seen, everybody gets consistent, high quality professional advice regarding their diabetes. Our nurses work the community clinics. We also provide a telephone service, so patients actually known to the service, we will provide telephone support, either asking the patients to phone into us or we will phone them. We also run a series of healthcare professional education sessions, which are spaced throughout the year. So we encourage people to also come on formal training, where we can actually update them formally. We're this year just starting a series of practice nurse networks. So each specialist nurse will be running probably 3 sessions throughout the year, fairly informal network meetings, trying to get all the practice nurses which that one specialist nurse works with together, sharing ideas, sharing sort of common problems, common themes, what works, what doesn't, how we can actually get them supporting each other with that specialist nurse as the linchpin in the middle. The other part of our role, which is obviously very important, is to provide that intermediately link between primary care and our secondary care colleagues. As with all long-term conditions, diabetes can only be managed by a multidisciplinary team. Our big issue or our big challenge is actually in a county such as ours, where we have one general hospital, where our consultants are fairly hospital centric, how we actually keep that level of communication open between secondary care and primary care. And we believe that the specialist nurses and the specialist nurse led clinic environment is the way that we sort of act as a conduit really between the two areas. What it allows us then to do is for patients admitted into secondary care, they're seen by our hospital inpatient nurse team. On discharge, they verbally and by writing hand that patient over to the appropriate community nurse, so that patient then isn't sort of lost in the net. The nurse then triages them. It may be that the patient just needs a phone call, or they need to be seen in a community clinic, and that nurse can then sort that out appropriately. The other thing that we'll do is actually support patients coming through the consultant clinic. So each consultant knows which nurses cover which area. So if they need a management plan put into action, or they feel that that patient needs one-to-one education or support, then they will refer directly to the specialist nurse for that patient to be seen within a nurse-led clinic, so that that nurse can then support that person through that lifestyle change or that crisis or difficulty with their diabetes at that point.
I'm particularly interested in your relationships with the multidisciplinary team? Because we were talking off camera about how almost nurse-led clinics in diabetes were some of the first in the United Kingdom. They've been around quite a number of years. So I suppose you've negotiated over the years a good working relationship with a multidisciplinary team. But could you just go through some of those? Have there been difficulties over the years? Has it naturally evolved as nurse-led clinics have developed?
I think, as you said, diabetes is one of the original specialities to actually have specialist nurses. And then obviously the natural evolution of that was to have nurse-led clinics and nurse-led projects. I think over the years in diabetes there have been issues, as there are in all specialities. I think what's interesting now for myself, I've been doing diabetes for 12, 13 years. The consultants, the young consultants that we're getting through now will actually say, we couldn't work without specialist nurses, just as we as specialist nurses would say we couldn't work without consultants. So there's a great synergy between the two disciplines because of the nature of the patients that we have. I think there are still challenges within the multidisciplinary team, certainly within our team, to fully engage podiatry and dietetics. And I think we all find that a challenge. I think we're very lucky in our area that our consultants are actually allowed to do some peripheral clinics. One challenge is always how you develop the balance between running a multidisciplinary clinic that doesn't become the nurse sitting in a room waiting for the consultant to send them the patient, which is not a good experience for the patient, not a good experience for the nurse, and not a good use of time. And certainly we found that challenging, to get the balance between doing joint clinics or directly referred clinics. Certainly, we're now moving much more towards a joint clinic model. Some of our specialist services within diabetes, so our preconception clinic, our antenatal clinic, and also our continuous insulin pump clinic, are all run with the specialist nurse and the consultant seeing the patient jointly. And that works incredibly well if you have the capacity to do it. Because obviously, again, what the patient is seeing or being able to be part of is a very joint conversation, a joint discussion around how's their diabetes now, what are their issues today, what are the main key things that we need to be working on, what does the consultant need to do, what does the nurse need to do, what does that person with diabetes need to do, and making a joint plan. And certainly our attendance rates from those clinics and some very small sort of in-house outcome questionnaires and patient satisfaction programs that we've run have all shown that actually patients quite like that approach.
And I'm thinking about your competence as well. I presume you're a nurse prescriber?
Yes, I am.
Which is, an interesting development for a lot of people watching around the world who don't do that. Has that been helpful? And can you comment on how you keep up to date and how you keep competent so you're providing an effective service?
I think maintaining competencies in specialisms is always a challenge, and certainly I'm sure my colleagues would agree. I know I have some clinical supervision links with some of my colleagues further up the country. And for us within the UK, although we have good links and we have fairly good travel links, and probably for people watching this around the world, what I'm about to say, they'll probably laugh and say, well, you've got very, very good links. We find it difficult to actually go to more national things from our end of the country. It takes us quite a long time to get there, so we're taking ourselves out of clinical work for maybe 2-3 days to get to some of the national conferences, etc. So we do rely heavily on regional support. So for example, as a nurse prescriber and as the clinical lead, I actually look for most of my clinical supervision from one of my nurse consultant colleagues in Somerset. So we're also getting that slightly out of county, a little bit further away. In terms of maintaining our competence clinically, we do have a clinical updating programme which we're very lucky that our community health services are very forward thinking in actually appreciating that specialist nurses especially do need to spend that time maintaining their competence. We do quite a lot of peer revision, peer supervision, so we do some of that as one-to-one, some of that as group. We also have an active education programme, so for each nurse there are core competencies and updatings that obviously they must maintain. They're the mandatory ones for all nurses, but we also have a set of diabetes mandatory competencies as well. So there's a degree of sort of clinical area of expertise, so ensuring, and that's done through some private study, attendance at regional, national conference and updating, and obviously trying to make use of some of the online and web-based learning that's there. Your question about nurse prescribing, I think for areas such as diabetes, nurse prescribing is going to be eventually something that will become mandatory. The nature of our patients, the medications that we're using, the complexity of some of those medications means that they need to be adjusted and managed often quite swiftly, very repeated changes in doses, changes in management. Nurse prescribing has been invaluable for that, and I think what it does, if we're all very honest about our management of insulin, particularly over the years, that's been very difficult to manage it safely and within the regulations. We've used patient group directives, which are obviously for people overseas, which is a directive signed by a doctor to say that within a certain dosage we are able to adjust insulin by phone or face-to-face until we get to an ultimate dose. Now obviously that leaves the individual nurse quite open. You have to difficulties. You have to be incredibly careful with your documentation, obviously recording telephone calls and documenting interventions with patients to make sure that you're working within that structure. It's very, very, very difficult to maintain. So nurse prescribing not only gives us the professional accountability, but the professional security to know that we're prescribing. And also I think what it does for a discipline such as diabetes is actually allow us as nurse prescribers and nurse practitioners to be treating the patient more holistically, not being what we in the UK are sometimes nicknamed as sugar nurses. So we get the blood sugar book, we look at the blood sugar, so actually trying to be more holistic.
And just finally, for those perhaps setting up nurse-led clinics in diabetes, perhaps not just coming into it from the beginning, are there any final tips from your own experience, Caroline, to give to nurses around the world? I suppose there's many, many, many tips, but perhaps a handful. Yeah,
I think some of the things that from our experience in Cornwall has been very much map a patient journey, think about that individual, who are all of those people that person with diabetes will come into contact with, and where as a specialist nurse or the person with the key person looking after that individual with diabetes, where can you galvanise people to help you? Because you can't support that person on your own. So your speciality and your expertise may be in supporting the wider network. The other thing I think is to start small. It's better to have 2 or 3 really well-run, efficient clinics that you're checking with your patients, is this working? Is it in the right place? Is it at the right time? Do we talk about the right things? Do we set the right agendas for you? So starting small and then spreading out. The other thing is, where humanly possible, to have somebody administratively to actually help you to do it. Nurses are good at being nurses, we're not good at being administrators, and I think that's one lesson that we've really learned, is we need to stick to nursing. We need people who are good at administration to do the administration.
Thank you very much.
Pleasure. One last thing. Obviously, if anybody would like any more information about the way in which we run our clinics, I'd be more than happy for people to email me or contact us to discuss what we do and how we do it and if we can be of any help.
Thank you very much.